Well, good afternoon, everyone. Welcome to yet another version of Challenging Conversations. So this Challenging Conversations series started about 6 months ago. It started based in the Maudsley Hospital and run by the Maudsley Learning part of our organization. The whole aim of the series was that people could openly debate the hot, taxing, challenging issues in psychiatry, in mental health today. So we've had challenging conversations about ethnicity and diversity. We've had challenging conversations about the use of psychological therapies. We've had challenging conversations about the training. Are we training people right for the future? Today, I am very unbelievably lucky to be joined by 4 people who I hugely respect and admire. Professor Robin Murray, who is probably one of the, if not the world's best known mental health clinician, and has had a huge influence on my practice over many years. And Feloy, who is a tremendous friend and advocate working on the Zero Suicide Alliance, and who has a carer, as a journalist, as a dramatist, has some really, really helpful things to tell us about today's topic. Joanna Moncrief is a clinician and academic and has very strong views about the future of psychiatry and the model that we might want to promote. And finally, bravely, we have Jacob Krzanowski, who is one of our junior doctors, who will tell us about the reality for him and many of his colleagues on the ground as we debate the issue. So today's hot topic, which we have a lot of people listening. We have people on the board of South London and Maudsley listening as we think about our new strategy. We have partners from the local community listening, because one of the most asked questions, one of the most issues most talked about in patient complaints, compliments, and focus on outcomes is, do we need medication? Are we using it properly? Is its time past? If we do have to use it, are we actually training people to use it well? What's the evidence on it? So we're going to start today. I will ask each of our panelists to just speak for a few minutes about their perspective on this issue. And then as subjects come up, we will look at those challenges issued forth, and we will ask questions. If people listening want to write those messages, if you have any questions you want to put in the chat, we would really welcome that. And just to say to you all that this session has been recorded. Those recordings will feed into the heart of the development of South London and Maudsley's population mental health strategy going forward. So, Robin, could I get you to introduce yourself properly and talk about this topic today? What led you to so kindly give up an hour of your time to come and talk to us today?
Well, of course, life in lockdown is not terribly exciting. So this is perhaps the most exciting, no, definitely the most exciting event of the day. So it's not much of a sacrifice. So on the term of medication, it's a bit like saying, what's your view on physical disease, or what's your view on medication for physical disease? There's different medications and there's different issues with the different medications. I mainly look after and have been interested in doing research into psychosis. And so the people I tend to see are people who've had a psychotic episode. And I think there is a very good case for antipsychotics in most people with severe acute psychoses, and they can often help to prevent a return of psychosis in the months and even the early years of following a psychotic reaction. I think there's much less evidence concerning the long-term as to whether it's a good idea for so many people to be on antipsychotics for life. And somehow or other, there isn't evidence for this. There's only evidence for up to about 3 years. It's very difficult to do double-blind studies that, say to somebody, you may be on an antipsychotic for the next 10 years, or you may be on a placebo. I mean, that's really not ethical and impossible to do. So we really don't have very good evidence for the long term. I think my hunch would be that very many people who are stuck on antipsychotics could very much reduce their medication or get off I'll give you one example of a young man I saw in the early 1990s, and he had a very severe psychotic reaction, and we gave him, actually with his agreement, he was quite willing to take a medication called olanzapine. And I wrote to, he was referred from another psychiatrist. I wrote to the psychiatrist saying he's currently on 20 milligrams of olanzapine, but I'm sure this could be reduced. I would hope that he would function better on a reduced dose. 20 years later, his mum contacted me. He was still on 20 milligrams of olanzapine. He had been referred back to his GP. His GP was frightened to change it. And of course, he had put on, maybe about 6 stones in weight, and he could hardly get out of his bed in the morning. So he is someone, I think there's far too many people like that around.
Thank you, Robin. And I think as a psychiatrist who worked with people often on long-term psychoses and started on elephant-sized doses of medication and kept on them for years, and then becoming that huge obesity problem, the diabetes problem, and others, I absolutely hear and resonate. What you're saying resonates with my experience as well. Joanna, you are one of our leaders at the Royal College of Psychiatrists, wanting to see a different approach to things. What's your view?
Thanks for inviting me on, Geraldine. It's nice to be able to come and talk to you. So, yeah, my view is that we overuse psychiatric drugs, but maybe more importantly than that, that we fundamentally misunderstand what they're doing. And that applies to all different sorts of classes of psychiatric drugs, although I would agree with Robin that that when we think about the pros and cons of drugs, that very much depends on the sort of drug you're talking about and the sort of problem that they're being proposed for. So I think that some people are helped by the effects of some drugs in some circumstances, but many people are not, and many people are, I think, overall harmed by them as we use them at the moment. So the basic problem, I think, is that we have this idea, we've come to have this idea that drugs work by targeting and helping to reverse or to rectify some underlying biological abnormality. We often think of that as a chemical imbalance, but sometimes people talk about abnormal neurological networks, for example. And what I'm saying is that we have no evidence that that's what drugs do. What we know that they do is that they change normal mental functioning. They cross the blood-brain barrier, they change the way the brain normally works. And what I suggest is that is how they're working. They're working by modifying normal brain functions. And sometimes that can be helpful, sometimes it can't. So I think it's easiest to talk about some examples. I would agree with Robin that antipsychotic drugs can be helpful for people with an acute psychotic episode. That is because these are drugs that are strong, very strong sedatives. Their initial name was tranquilizers, major tranquilizers, in fact. And they slow down thinking, they slow down movement. They work in a variety of different ways. I don't want to suggest that they're all doing exactly the same thing, but by and large, they are sedating substances, but they produce a distinct sort of sedation, which slows down thinking and dampens down emotions, very importantly, without simply knocking someone off and sending them to sleep, as other sedatives like benzodiazepines and barbiturates do. And it seems that that effect of slowing down thinking and dampening down emotions in particular is really useful if someone's acutely psychotic. And this was indeed how these drugs were understood back when they were first introduced. People talked about how they helped people to distance themselves from their psychotic symptoms. So often they still had some delusional ideas or some hallucinations, but they weren't any longer preoccupied or, most importantly, really distressed by them. So I think understanding how drugs modify normal brain processes is the important thing. If we think of a very common condition like depression, antidepressants are drugs that, again, do a variety of things, and some of them may probably do dampen down emotional responses, again, not as strongly or in the same way that antipsychotics do, but they do seem to numb people emotionally. And when people come off them, they talk about being sort of over-emotional, labile, tearful, as if that sort of clamp on their emotions has been suddenly removed. So obviously, if they have those effects, they are going to have an impact on someone who is depressed. I'm not convinced that having your emotions suppressed when you're depressed is actually helpful. It may be what some people are looking for, and some people may feel that it's helpful, but I think probably it's better for people with depression to get through the depression with using other means and other techniques, rather than to just have it numbed and blunted by drugs. So those are my main thoughts. I'm happy to sort of take up, and respond to questions and take up other issues.
That's absolutely tremendously insightful. Thank you very much, Joanna. Really, really clear position. Thank you. Can I turn now to Anne? Anne has been an amazing champion for an advocate for mental health. I think one of the most wonderful things to me as a psychiatrist who's been around for 4 decades is the real strong growth of the patient and family movement in mental health. To give us a different perspective as clinicians, but also to help us see what we need to improve. And would you be willing to tell your story and all the amazing work you've done?
I'll unmute myself first, otherwise I won't get very far. Thank you, Geraldine, and everybody here for inviting me onto the programme today. And yes, I'm here because I have suffered the most devastating loss in losing my son to suicide. And Oliver was 22, just 2 days before his 23rd birthday. He had such a happy and fun-filled life, lots of friends. He'd graduated from UCL actually at 6 months earlier, before he died, and he'd got a first in history. And he travelled the world in his gap year. He'd had an amazing life, a good family, lots of opportunities. And then very quickly and dramatically, he became very depressed after working in China for a little while. And so without a history of any mental health issues, had the experience of going to his doctor saying he was unhappy and low. And the first initial contact was to say, well, let's get your thyroid checked out. You might have low mood because of that. So he had his blood taken on a second appointment by a nurse. The thyroid was fine. He had been asked if he'd had thoughts of suicide, and he'd said no on that initial doctor's appointment. But when he continued to become very anxious as well about what he was doing with his life, he was someone that was always had a lot of sense of purpose and direction, suddenly not having that, and feeling very unsure about himself, he then made another call, and the doctor then over the phone, another doctor this time, prescribed him citalopram. It wasn't a face-to-face appointment. He took that for 4 days. It massively increased his agitation. And in the middle of the night at his home, he took his own life. So that's at the point which I then come into this, the medical profession, having not had any mental health issues myself, to suddenly find myself thinking really seriously about what happened and how we can prevent the further loss of suicide. I set up Ollie's Future, his charity in his memory. And it's been interesting that my work has been led in the direction of primary care because firstly, I was staggered that actually it isn't a nice guideline that you have to be prescribed face-to-face, that you have to be prescribed antidepressants face-to-face in the first instance. When I brought this up at the inquest, the doctor made it very clear that he had done everything as according to procedure. So that was shocking, because I know for a start my son would have presented very well, very articulate, very pleasant on the phone. And yet I think had he been seen face to face, I think it would have been a different matter. The doctor just said, come and pick up the prescription at the in-house pharmacy, which he did. So that was the first thing that then led me on to looking more into working with primary care. And I was fortunate to be asked to be the patient's carer lead on a new pilot called Practice Hope. We came up with the name, Always Have Hope, I think is so important. And that was working with 30 GP practices in Sussex, Surrey and Kent. It was funded by Health Education England. And we worked with those practices to try and look at best practice using a pace setter model, which is the NHS pace setter quality improvement model. But what was so interesting was to work and co-produce this with the doctors, but also with young people. It was focused on the 10 to 25-year-old age range. And so it's led on to me now actually taking this forward and working directly with NHS trusts. In fact, we're rolling this out digitally because of COVID. We've moved it onto a digital platform, which actually will mean it's more accessible to everyone. So Warwickshire County Council and Coventry and Warwickshire NHS Trust are the very first, which we're rolling out now. So, I mean, there's so much more information in there that I can tell you about, but it is really looking at mental health in a completely different way, making communities more suicide safer. And that means every one of us being able to understand or be able and confident to have a conversation about suicide, not for this sort of knee-jerk reaction to think someone's suicidal, let's put them on some antidepressant. Clearly, that was the very worst thing that happened in my son's case. So, yes, it's new ways of thinking, nice guidelines changes, and also something like a warning on the side of the medication box. Why isn't there? Like a packet of cigarettes, why not? You know, this could increase the risk of suicide in under 25s. These are simple things I'm talking about within Practice Hope. They're simple things. It's just thinking more holistically. So that's where I come in.
Terrific, Anne, thank you. And that learning from what's been successful in other worlds is something that we're gradually as well with the digital world opening up more to, I would say, mental health. Which brings us to our final panelist to kind of tell us what he thinks. So this is Jacob, who is a senior junior doctor living with the reality of on-calls, busy caseloads, and hearing, you know, people say, we've heard people say that the main reason for sectioning somebody under the Mental Health Act is that they can be forced to have medication. What's the reality, Jacob, of life as a junior doctor, and what should people on the board and people on this call listening who have the ability to improve things, what should we be doing to support your views or to support what you think needs doing?
I mean, having sort of familiarized myself a bit more with what Robin has been publishing more recently, and then Joanna has been working on for quite some time, I think there's a sense amongst trainees that there's a much greater need for a nuanced and much more sophisticated approach to medications than the one that I think is currently being, I think, widely sort of used. So I think that there's not a sense that medications don't have a place by any means, but I think there's a kind of growing awareness that the way in which they're being prescribed and the sort of the way in which medications end up moving through someone's sort of life course is something which could do with much more, I think, considered planning and an awareness of, I think in particular, sort of patient experience, but also being open to and catching up with a lot of the awareness that's been coming about, such as a kind of greater acceptance and appreciation of withdrawal conditions from SSRIs and sort of the growing understanding around sensitization with antipsychotics. And so I think that I've come to this discussion because of my own background and sort of interest in, I think, looking at sustainability in mental health services. And if it has anything to do with this discussion, I think it emphasizes the point that going forward, we can't continue working in a model which is so reflexive and based around acuity, and that there needs to be a much greater emphasis and appreciation of preventative causes and preventative care. And so I think a big question for a lot of colleagues would be, can psychiatry sort of step up to be a much more sophisticated and ambitious version of itself, which looks to treat people rather than just a disease-focused model? And I think right now we're at a moment where deciding which way we go will very much depend upon sort of my generation and the generation below us. But I think there's a lot of understanding that Robin and Joanna have articulated that hasn't trickled down into practice. So, I mean, some things that I personally would like to see is I've always been trying to understand why there's such a lack of qualitative research and the sort of, I think, what feels like a kind of marginalization of qualitative research in a field of health, which is fundamentally interested in experience. So if you look to see data and research about patient experiences on wards, it's very difficult to actually find any good work done on that area. In addition, I think there's a real awareness amongst those working in frontline services that some of the barriers towards creating a more sophisticated approach to medication is the sort of fractionalization and siloing of the various bits of the system which make up a good mental health service. So, there's, as opposed to being a sense of collaboration between acute wards, CMHTs, home treatment teams, social services, I think it can often feel like a relationship of antagonism. And I think with that in mind, if we're going to look to take steps forward, if we're going to look at how training is going to be shaped, yes, you can look to change training in some sense, but I think there's always a danger of it feeling like lip service to the point of view of a trainee, because training is ultimately reflected in the clinical service in which you're existing. And I know that if those changes aren't happening at a systemic level across clinical services, the training experience will only be as good as what the system can offer. And at the same time, I know that there are places that are doing medications, and I think a much more in a way which takes into account the kind of qualitative experience of patients and is much more measured and sort of nuanced. I know colleagues that I've spoken to on call that have spoken about their experiences in Australia and elsewhere, where it feels like there's a much greater consideration around the sort of reality of the side effects, but also what patients say. I mean, what comes to mind is, and this is the last thing I'll say, is that I think it's interesting that so often when I've spoken to patients who have been on antipsychotics, the first thing that they'll tell me is that they've managed to get some sleep. And then yet that's something that doesn't necessarily get considered. They don't tell me necessarily that the voices have gotten better or worse. And again, I deflect to Robin's huge experience as well as Joanna's, but I mean, I think it's really poignant to think that again and again, sleep is what gets sort of told to me about the benefits of olanzapine. And yet that's something that we don't have any discussions around sleep hygiene or a kind of an appreciation or curiosity in those issues. So that, if anything, is used a kind of case example of the fact that I think for whatever reason, we've turned a blind eye to patient experience with a greater emphasis on, I think, the disease model. Yeah, that's it.
That's just really, really great. Thank you very much, Jacob. Robin, do you have a reply to some of the challenges that Jacob's thrown out?
Well, also, I think also from what Anne said about her son's story, and I mean, I one can sympathize very much with this. And my view really is that antidepressants are given out like sweets, and that general practitioners are very busy and rushing from, I don't know, is it 8 minutes that they have with each patient, even if they're able to see them personally. And somehow psychiatrists have outsourced the care of people with complex psychological problems to general practitioners who have a million other things to learn. And you can't be brilliant at everything in general practice. And so my view is really that, first of all, I think it clearly is that a psychological approach is much better than just immediately having an antidepressant. But also, if a general practitioner is going to prescribe antidepressants, that within a couple of weeks, the person should see a psychiatrist. General practitioners don't initiate complex endocrinological treatments. Or if they do, initiate them, they're referred immediately to an endocrinologist. The brain is much more complicated than the other organs, and yet somehow that we expect general practitioners to play the biggest role in treatment of depression. So I think there'll be a lot of people in Anne's situation who the way our system works is that you ought to be able to have a problem and see a psychologist or a psychiatrist immediately. That the problem of our gatekeeper system is that you can't do that. In many other systems, you would be able to do that. In terms of really what Jacob said, I mean, I agree with a lot of what he said. And one of the difficulties, I think, is that we've adopted a sort of automated model of psychiatry, that continuity of care has gone out of the window. And when I chaired a schizophrenia commission looking into people's care, I remember one lady saying that her son had been seen by, I think, 8 different psychiatric teams in 7 days, that he had been looked after by his own psychiatrist. He had got too sick and therefore had gone to the crisis team, then to the home treatment team, then admitted to an initial assessment unit, then to a general psychiatry team, and ended up in a forensic team. I mean, you're not going to be retelling your story to the 8th psychiatrist with any hope that it's going to be resolved. So I think specialism has lost. The thing we have to give our patients is care and kindness. And if you're able to do that for 6 hours and then the patient disappears off to somebody entirely different, I think as a therapist, you lose any individual contribution that they have. The final thing I would say is that I agree with what's been said twice, that I think we have to go very much more to prevention. That in medicine as a whole, prevention is a very common approach. In psychiatry, somehow or other, we're trained to treat the individual rather than the population. We work in South London, or most of us work in, sorry, John, but I guess the bits of North London that aren't much different. There are bits of South London that are psychiatrogenic. That is very difficult to be brought up in some areas of South London without encountering poverty, poor education, a drug dealer down the corridor, be subject to gangs and violence. As long as we have inner cities that are like that, we're going to have major psychiatric disorder. And yet psychiatrists and psychologists have been pathetic about talking about this.
Thank you, Robin. So that, I mean, I couldn't possibly, as a social psychiatrist, I couldn't possibly agree more with you. And I think one of my sadnesses is that in my for most of my working, we would work on the basis that, especially if somebody continues to have a problem, you couldn't possibly make a proper diagnosis or formulation or shared care plan unless you'd actually seen where the person lived and you understood the context in which they were living. Because how can you just, in a space, just treat a set of symptoms if you don't see these environmental contexts you're talking about, the adverse childhood experiences, the fact we know that 80% of the people I've ever worked with have had physical, sexual, or emotional abuse. We have more gangs. For some reason in this country, and for me, it's a big ethical question, we are one of the few countries where the use of the Mental Health Act is rising and rising and rising and rising. We have places like Italy and other countries where trainees are fundamentally taught about the art of mental health, the asking, the listening to the person, the understanding their life, and above all about negotiation skills. You don't prescribe something without actually real explanation and then negotiation about when to take it and how to monitor it properly and how to do things. So, that whole fundamental principle for me as a social psychiatrist, that you can't understand someone if you don't understand the context of their life. It's kind of interesting how that resonates, as well as the continuity of care issue. So Joanna, can the Royal College of Psychiatrists, and particularly your movement, can you help with this? Because I don't know where the lobby's coming from now that changes clinical practice. We've got fantastic long-term plans, policy plans, which are about service models. Robin says teams and systems, but the nitty-gritty of the understanding, the working with a person to understand their life and how then the clinical interventions flow. Whose job is it to try and change that? Because I can't quite see where that comes in at the minute.
So thanks, Geraldine. I will answer your question in a minute. But first of all, in response to Jacob and partly to Anne and Robin as well, I also wanted to talk about this issue of prevention because, like you've just asked me, I am often asked, well, how should we do things differently? And I think the first thing to say is that we have to stop prescribing so many drugs. We as a society, I'm not saying just we as psychiatrists, but we as a society, because I think they can be so harmful. We've heard of, we've heard Anne's tragic story. I think what happened with antidepressants, the new, SSRIs, when they were introduced in the 1990s, is everyone thought, oh, they're not as toxic as, barbiturates or the old antidepressants, so they're fine. So let's give them out, willy-nilly. And, then we've gradually realized that actually they can cause serious withdrawal problems when people want to come off them, especially if they've been on them for any length of time. So people can get stuck on them for years and years. They, rarely, I think, but they do, increase agitation and drive people to suicide, unfortunately, very occasionally. And they cause sexual dysfunction. And in some people, it seems that sexual function persists when they stop the drugs. Now, we're prescribing these to a lot of people, and if only a small proportion of them get persistent sexual dysfunction, that is still a large-scale tragedy. So I think the most urgent thing we need to do is to stop starting these drugs in the first place. And on the subject of antipsychotics, Robin already mentioned how, long-term use is not that well evidence-based because the trials aren't long enough. There's also this problem that the trials are all discontinuation trials. And once you get onto a drug like an antipsychotic, it may be the case, there is some evidence that when you stop it, your risk of having a relapse is even higher than it was before you started the drug, i.e. there's something about stopping the drug that actually precipitates an episode of your underlying condition. And so it's really important that we don't get people onto these drugs long term when we don't need to. Plus, there is a bit of evidence that for some people at least, they might do better if they don't get onto long-term medication. They might function better because of the effects I was describing at the beginning. If you give something to someone that slows them up and dampens down their emotions, you can see that in the long term, they probably don't function as well. And I just wanted to get in a quick mention for the RADAR study that I'm running, which is a randomized trial of comparing antipsychotic maintenance treatment and a gradual process of reduction in people with schizophrenia and psychosis to see if it's possible to help some people come off their long-term antipsychotic medication and to look in particular at what the long-term outcomes of helping people to do that are. So I think it is just really important that we keep in mind that, if we're going to talk about preventing mental health problems, it is really important that we do no harm, and therefore that we stop prescribing as widely and indiscriminately as I feel that we now are. And in the long term, what do we need to do? I think in order to do this and in order to have a different sort of approach that's more constructive, I think we need to reorientate ourselves away from the idea that mental health problems are diseases, that mental health problems are medical conditions in the same sort of way that lung cancer or pneumonia is a medical condition. I think we need to understand them as human and as social problems, and we need to address them in that way. And therefore, I would completely agree with what you were just saying, that what we need to be doing, and what Robin was saying, is what we need to be doing is addressing some of the many social problems that definitely drive many of the people to our clinics, and would drive many other people in the same circumstances to our clinics. Poverty, inequality, insecurity, rampant drug use and drug dealing and crime, and all those other sorts of things that people have to deal with in many parts of our society. So.
Thank you, Joanna. And can I just say that on the chat, there have just been so many people that have thanked you profusely for sharing Ollie's story, which just absolutely has totally brought to life why this is such an incredibly important subject that we talk about openly in mental health. So thank you very much for that. You were about to reply and I stopped you.
I was just going to say, it's so refreshing to be listening to these thoughts and comments by everyone here, because having now done a lot of surveys, part of Practice Hope, we asked the doctors about their own mental well-being and their own confidence and competence in dealing with, this is for 10 to 25-year-olds, but quite honestly, it's across the board. And they often don't feel confident or competent about having a conversation that is about suicide. It can be about suicide ultimately. And so, you know, we've gone back to the table. We've created some training that addresses this. And it led me to thinking about, why is this sort of culture of just prescribing antidepressants out there? What is happening? And talking to the young doctors, we've developed another initiative. As you say, Gerald, I'm very practical. I see something that he's doing and I do it, or try make an attempt. So we've developed something which got BMA funding, actually, called Dr. SAMS, Dr. Suicide Awareness in Medical Students. And again, you know, this emphasis on the drug, the medication side, and yet they don't even have the basic 2-day assist training, applied suicide intervention skills training, which I did about a year after I lost Oliver, because I wanted to know, what on earth should I have done? I wanted to know what could I have done. He went rapidly down in 5 weeks. Someone who had left England being very happy, came back troubled. 5 weeks, we lost him. So I wanted to know myself, and it's led me to realize that most people can talk about mental health. We don't have to have this attitude in this country that only the medical professions can deal with this, and that once you go to the doctors, you're going to be prescribed a drug. I think we've sort of need to go away from all that. And so, working with the junior doctors at Brighton and Sussex Medical School, we're actually teaching there a 90-minute training talking about suicide. It's revelatory. There isn't much training in their whole 7 years to ask these questions and have a conversation. But we also do it for them to have the conversation with their colleagues, their other friends on the course, because we know that there's so much pressure. So, I mean, it comes back to being far more comfortable about talking about mental health and suicide. And that is going to make our communities stronger. And that's why, we can do that. We're able to do that if we can listen, if we can learn to listen and support. What a much stronger society we would have. And there's, working with the doctors in these surgeries, doing the surveys, we've realised also, we've surveyed young people. Over 75% of young people that we surveyed didn't know they could go to a GP surgery for mental health issues. And of those that do, 20% that we surveyed said they wouldn't ever talk about feeling suicidal to a doctor. So these are just, and what's so lovely is we get the statistics, the information that is local, and then we support the GPs by telling them actually what is out there. Often they don't know that there are amazing support groups that could help young people or of any age. There's some sort of disconnect, isn't there, that's happening. And I feel sorry for the doctors. I do. I feel sorry for them because they are, I think, you know, as Robin said, you know, they've become the sort of depository for sort of giving out all the drugs. It's got to change. It's really got to change.
I mean, I'll read to you a few of the comments in the chat because I think they're kind of, there's just so many fantastic comments, but these are really interesting. So we have a GP in the audience, Surinder Singh, who says, as a GP who does prescribe, I also think we give these meds out as if they were Smarties. We really need to be exercising diligence, our clinical judgment, and a bucket full of care and kindness. And care and kindness isn't just about dishing out antidepressants. We have a very, very helpful, I would say, very, very important comment from one of our first chats, which is talking about the impacts of antipsychotics on people from BAME communities, the greater likelihood of having side effects. And is that ever taken into consideration in our prescribing of antipsychotics? We have very helpful and interesting comments as well about, does Robin really think that the policy and the long-term plan will give us will give people the continuity they need, or do we actually need to change the model of clinical care before we even think about what teams we need? So these are just some of the comments in the chat. I think it'd be helpful if we could address that issue about people from BAME communities. And do we have specific, given that at SLAM, over 50% of the people that we serve in our local populations come from a very diverse range of communities, African, Asian, Eastern European, a whole different set of people. We know that from interpreters' point of view, Spanish and Portuguese are the two languages for which we at SLAM employ the most interpreters to help with the communication. But do we take into account sufficiently the impact of antipsychotics on people from BAME communities? Robin, would you have a comment from the literature?
Well, I think when we think of minority communities, I think the biggest problem clearly is in relation to the Caribbean and African origin communities. That the rates, I mean, there obviously are that people, all migrants are more prone to psychiatric, have a greater risk of psychiatric problems. It's understandable. You're away from where you were brought up and where you understood the culture. But I think particularly we for 40, 50 years, there's been research and discussion about the high rates of psychosis in the Black community in the UK. And at first we thought maybe it was migration, but then the children of migrants also have high rates. And I think we sometimes now accept that there's really three bits to it. One, there's what happens to people before they migrate. Now, some people migrate coming from the Caribbean. Most people came to get a better job, but coming from Syria or coming from Afghanistan, you may have been traumatized. Your family may have been killed. Then you have to go to perhaps struggle for months and months to actually get to the country you want to go to, or you have to try and cross the Mediterranean in a rubber dinghy. So there are all sorts of traumatic experiences. And then you get to the host country, and what happens in Britain, you get locked up in a prison, or what it looks like a prison. And you may find yourself subject to all sorts of discrimination. And of course, the discrimination goes down several generations. So I think there's all sorts, we can understand why you can teach paranoia. If people are regularly subjected to discrimination and they learn that people out there are against them, maybe after a little while, after a couple of decades of this, they begin to think society is against them. So we have these difficulties, and then people come into I think one of the great things is having psychiatrists and psychologists from the same ethnicity. And although our psychiatrists are very diverse, we have lots of non-UK psychiatrists, but we don't have very many African or Caribbean psychiatrists and psychologists. Psychology is still predominantly a white profession. So I think getting people of the right ethnic or the same ethnic origin. Final point on this, I think, is that my personal belief is that for all of these reasons, when people from the Black community get disturbed, if they have a mood disorder, they're more likely to show some symptoms of paranoia and get labeled as having schizophrenia. And when they should be really being treated for a mood disorder, they're treated for having schizophrenia. So that would be my view on that question. If I could just touch on what you said about the Italian model. I know quite a bit about the Italian model because, as you know, my wife is Italian. Psychosis is only about a quarter as common in Italy as it is here, for very interesting reasons. But Italian psychiatrists have a nice, easy time. They're not bombarded by huge numbers of patients like we are in London. And the other thing is that you don't get socially isolated in Southern Europe. Again, my wife, who comes from Palermo, says, you don't get a social isolation doesn't exist in Palermo. Social intrusion is the problem. Everybody knows your difficulties. I think we could do with a bit more social intrusion. And maybe one of the side effects of the of COVID is that there's much more discussion about our neighbours and much more discussion about our and their mental health. So maybe there is a springboard here.
Good. Terrific, Robin, as always. So two kind of, I think, final themes before we close down. The first one is comments saying, so clinicians, surely we do need to stop prescribing so indiscriminately. Use of antidepressants is the largest intervention for the treatment of depression in primary care. It's much larger than IAPT or anything else. So people agreeing with you, Joanna, saying we need to stop prescribing indiscriminately. But I think really, really heartfelt comments from trainees saying we're often under pressure to prescribe, and surely clinicians adhering to NICE guidelines would achieve at least much greater safety and effectiveness. And the comment is that most frontline clinicians are not even familiar with NICE guidelines. How can we ensure that happens? Does the panel have a view on that? What's our call to action from the panel?
Gosh, well, I would say every surgery should have Practice Hope, a Practice Hope champion, because that's exactly, we're at grassroots level, working with the doctors, getting, hearing them, listening to them and listening to the patients. But it's a big ambition.
Yeah. Jacob, have you been in anywhere in your training, did you have formal training about the NICE guidelines? I mean, we do have about, I think, 159 at last NICE guidelines in mental health. We have public health ones, we have kind of social intervention ones, we have ones by diagnostic groups, we have ones by different therapies, we have ones about healthy lifestyles. Do you get that training? Is that anywhere in your training?
Yeah, I think the exams do reflect and understand. You need to have quite a good understanding of what the guidelines are. That having been said, I think that the way the system is now designed, and I think this is said about any system under strain, is that there's a real reward for doing rather than not doing. And as I kind of mature as a clinician, I'm aware that the sophistication comes from knowing when not to do things. And so at the same time, when you sort of move through the kind of clinical spaces, there's a lot of prescribing being done by any number of clinicians of various degrees of development in their kind of careers, which are using polypharmacy. There's no necessarily understanding of the kind of the duration of the medication. and how long it should be had. And so although the NICE guidelines, I think, are obviously well thought out and people can say that they know them, again, this system which rewards doing rather than not doing, or that it's much more, it sort of facilitates and doesn't necessarily champion an absence of action, or at least or recognizing that an absence of action is just as important, if not more difficult, then it becomes very difficult for trainees and for clinicians generally to uphold the NICE guidelines in spite of the fact that they might be evidence-based. So, I mean, that's what I would say in terms of the fact that I think the awareness is there, but I really do feel that the system is quite constrained, and in that condition, it's much harder to think, and it's much harder to feel empowered to not prescribe. And it's sort of reflected in the kind of culture of prescribing that we're sort of immersed in.
Okay, so can I just throw into this kind of challenging conversation one of my own bits of thinking at the minute, which is we have come quite a long way in many aspects of mental health in this country. We do now have the majority of people talking about their mental health. I mean, my time as National Clinical Director, my ambition was that people would use the word mental health as freely as they'd use the word physical health, because then we would start raising awareness in society and we would start getting more creative thinking and hopefully more prevention, and people like Anne coming to the fore as leaders. And I kind of feel that that was an ambition I set myself, and I feel very, very pleased that we're kind of much further ahead. But when I now look at what does the world expect of us, in the same way, what does it expect of cancer therapists and other kind of, people who look after stroke and so on? The world expects us to use good practice. And when I look over and over again in mental health about, we've got fantastic research and evidence, we have these NICE guidelines, which are the envy of the world, but what we have not got yet is the implementation into practice, practical things happening. So in the acute sector, the physical health sector, they have had far more resourcing for several decades now into organizational development, into mapping implementation pathways. They're more familiar with things called SOPs, standard operating processes. I had the privilege a few weeks ago to speak to senior leaders in the aviation industry. And the aviation industry, you may remember, was one of the least, was regarded as an unsafe part of our world a couple of decades back. But over the last 15 years, they have become one of the safest businesses and industries. And their view is that the way they've done that is because whenever they're going to introduce, they were going to introduce a NICE guideline, they would not introduce it until they had sat with patients, customers, frontline staff, and over again went through. So who, when, where, how, with what support in the most efficient way can actually take those actions. And I'm just wondering, is this where we're kind of at in the history of mental health? How do we start supporting our clinicians, our patients, to kind of do the things that we know the evidence tells us we should be doing?
Can I make a comment, Geraldine?
Please do, Joanna.
Thank you. Yeah. So as Jacob said, it's difficult to do something. It's much more difficult to do nothing rather than to do something. And therefore, it's easier to start a drug than it is to stop it. And I think that I think what we really need to address is the expectation that that difficulties in living, that anxiety and depression are medical conditions, I'm afraid. And I think we need to do that by having a different sort of service where people can go to when they feel desperate. And a model I would suggest maybe is the child and adolescent mental health services, which are, or at least used to be, embedded in social services rather than in psychiatry. And maybe, I think that would maybe be a way of getting away from this disease model. There would be a medical, there could be medical input for when there was a need for medical intervention, but fundamentally it would not be a medical service, and therefore the expectation would not be that you come out of the consultation with a prescription, because I think this is the main problem. By the time anyone goes to see a psychiatric trainee, they're already on antidepressants, and often they've been on them for months. And, you know, they've then got the idea that they have a disease, and it can be quite difficult to change that and to encourage people to see their problems in a different way and go down a different route. So that's my carte blanche for the future.
I mean, there was some very good research done at least 4 decades ago, which showed that the most effective profession to be based in primary care at the front door, particularly for women and children and people who are vulnerability to depression, were social workers. Very evidence-based. Rosalind Corney did it, really, really great study, and then the world changed and it got completely forgotten. So it's interesting that some of these great ideas come back again. So
that's interesting. Yeah.
One final comment from each of you. What would you want, what action would you think should be taken from this debate that we've had today? What one thing would you say that might actually make a difference? What should we do? And
I would suggest having this conference, this talk, on a much larger scale. I think this has been a great forum, and welcome the chance to move away from so much prescribing and more integrated social and health care.
Thank you. Jacob, you of the future.
Right, I'm sort of anxious about in any way being associated with that mantle, but you know, I think I can speak for myself and the people that I meet with her on a regular basis. But this is an awkward point to be made, but I think it's very hard to have a honest discussion and to have people feel as though they can speak openly about their experience working clinically. And it's not a question that's easily answered, but I think, you know, take any system, in this case, SLAM, how do you create a space where people feel really comfortable voicing their experiences of how they care? And I don't have the answer for it. I think obviously by your incredible skills, Geraldine, I think you've happened to facilitate that space, but I think it's very difficult. And so I would probably echo what Anne said in terms of, if you don't have those discussions and people don't feel like they can speak authentically, and I think that ties into your point about the input from the aviation industry. And I think there has to be a very kind of honest understanding of who needs to be in the room, right? Is it occupational therapists, nurses, GPs, or are we just going to have psychiatrists in the room again? Because I guess so many of the problems we're facing at the moment require us breaking down the barriers and sort of enforcing relationships. So.
Thank you. Robin, final comment.
I think I would agree with Jacob that psychiatrists can't resolve this, and psychiatrists become overwhelmed. There's no social worker. The waiting list for psychological treatment is 18 months. So what do? We switch the medication. So we need to have a much greater role for non-psychiatric, non-medical professions. I think we need to put lots of resources into psychiatrists standing up and saying the way our society is structured. I'm admiring of Michael Marmot. We need to have a 35-year-old Michael Marmot for psychiatry. And last of all, I would ban general practitioners for prescribing antidepressants for more than 2 weeks.
Great. Joanna, are you going to change this at the college? Just final 30 seconds soundbite, if that's okay.
Yep, it's fine. I think we need to get away from the idea that we are treating diseases or medical conditions and recognise that what we are doing is helping people to address their problems.
Thank you so much.
I think that would help.
Been an absolutely wonderful panel to have today. Thank you so much indeed. Fabulous insights. And I'm on the way to organise this big conference already. Take care, everybody. Thank you, Maudsley Learning team, as always, for your organisation and tech skills. Cheers. Bye-bye.